The broadcast is now starting. All attendees are in listen-only mode.
Good evening. This is Bill Jolly. I'm the Vice President here at the Tennessee Hospital Association. And the title of tonight's presentation is Tennessee Healthcare Innovation Initiative, Primary Care Transformation. And the intent behind tonight's webinar, we're really looking at providing some additional resources to the primary care providers in the state and utilizing information that would enable them to make informed decisions as they look at transitioning from a fee-for-service to a value-based payment system. Some of the learning objectives from tonight's webinar including discussing Tennessee's 3 primary care transformation strategies, reviewing tools to assist in care coordination, looking at the benefits of participating in new healthcare delivery models like patient-centered medical homes, and also discussion and an outline regarding episodes of care. Tonight's speaker is Dr. Vaughn Frajean. He's the Chief Medical Officer for the Tennessee Healthcare Finance and Administration's Bureau of TennCare here in Nashville. He supervises the medical, dental, and pharmacy programs for the state. He is particularly involved with issues of healthcare expansion and payment reform that will significantly shape the way care is delivered in the future here in Tennessee. Dr. Frajean's presentation will review TennCare's role in the state's healthcare system and discuss payment transformation and how it will impact primary care providers. We are just extremely grateful to have Dr. Frajean presenting this information to us. Dr. Frajean?
Great. Well, thank you very much for the introduction, and thank you for the opportunity to speak this evening. It's an honor. And I'd like to keep this discussion as informal as possible. And at any time, if anyone has any questions, please feel free to stop me. I'd like this to really be focused on what your interests are. And the topic of payment reform and primary care transformation and where it's going in the state is a broad one. And the presentation I have is a pretty broad one as well, covering a lot of different things that we're doing within the state. And so I'm going to talk a good bit about primary care transformation and the patient-centered medical home model, but also touch on a couple other issues that I think are tangential to primary care and to the transformation around PCMH, but also touch on it pretty broadly. So don't hesitate to stop, ask me questions either through the portal or just over the phone as well. So let's go ahead and get started. And the first slide shows a picture of Governor Haslam. And so to talk about where we are today, I have to go back a little bit in time. And we'll go back to March of 2013 to a speech that Governor Haslam gave to the joint session of the state legislature. And in that speech, the primary news that came out of that was that Tennessee would not be a state that expanded under the Affordable Care Act. And there still are a lot of ongoing discussions around that and a lot of discussions about the future of what the Affordable Care Act is going to look like with the new administration coming in January. But the other big news that came out of that is not directly related to anything going on with the Affordable Care Act is that he talked about the need to improve and transform the way healthcare is delivered in the state. And he talked about the amount of money that we're spending on healthcare, and he spoke about the TennCare program, but also more broadly about health of our citizens in general and the opportunity to improve the value of the care that is being provided, to improve the quality and improve outcomes, and at the same time to talk about cost effectiveness, and talked about the fact that the growth of our healthcare spend in the state and nationally is not sustainable, and we need to develop a process and a system where we improve the way healthcare is delivered broadly. And the other thing that he did in that speech was to challenge and charge the TennCare, our state's Medicaid program, with leading that initiative. And that's what we've been doing since 2013, and that's basically what I'm going to talk about for the rest of the presentation today, is what TennCare has been doing in terms of leading discussions and moving forward with initiatives to reform the healthcare system, and very overtly talking about improving the value of our system and in terms of both improving outcomes and improving cost effectiveness. The other thing to factor in here is that this is not just a Tennessee initiative, that there are programs across the country that are looking towards these value-based payments. CMS has had several initiatives they started within the last couple of years around the Medicare program. There are many other state Medicaid programs that are involved with trying to transform the system. Commercial payers across the country have been involved with this. Medicare Advantage plans are very interested in doing this. So across the whole spectrum of the payers in the healthcare system right now, they are looking for ways to move towards greater value in the way healthcare is delivered. And there's a lot of definitions around how that could be measured, and we'll talk a good bit about that. But this slide is just showing us that payers across the whole spectrum are involved in these kind of discussions. And as we were charged with leading the initiative in Tennessee, we quickly realized that TennCare by itself could not make major changes to the healthcare system. We have about 1.5 million enrollees in the Tennessee Medicaid program right now, so a little under 25% of the state population, which is certainly significant, a significant portion of the population and a significant portion of the overall healthcare spend, but it doesn't nearly get us all the way to making the changes that need to be made in the system. And so we have tried to bring essentially all the major payers in the state to the table as stakeholders as we've initiated our reforms. So our three managed care organizations within the TennCare program, which are Amerigroup, United, and Blue Cross, are all intimately involved with this process, and each of them have commercial units as well that are involved with the movement, and in addition they have Medicare Advantage plans. And in fact, the only major payer in the state that has not been actively involved in the discussions that we've had has been Medicare fee-for-service. And we've had discussions over the last several months with CMS about ways that we can coordinate the programs that we're developing with some of the initiatives they have around payment reform as well. So we are trying as much as possible to have a united approach that will be in the best interest not just of the payers, but also of patients and the providers across the state as well. So as we look at the next slide, it talks about the three primary strategies that we have brought to the table as ways to reform the system. The first is around primary care transformation, and that's where I'll be spending the bulk of our talk today, and that's the patient-centered medical home model and the studies that have shown that the optimal way to improve population health and move towards a system focused on wellness is to develop relationships between the primary care doctor and their patient population, and we'll talk about how we're going to do that around the patient-centered medical home model that we're developing, and some subsets of that as well. The second prong of this approach has been around episodes of care, and these are designed to be more acute or specialized interactions between a patient and the healthcare system. And we started in 2013 with designing these episodes of care, and now we've just completed our sixth wave of these episodes, and I'll go into some detail about how we're doing that and what those episodes look like. But there's a significant interaction between the primary care and patient-centered medical home model that's been developed in these episodes of care. They often overlap, and our goal ultimately is to have a holistic approach to healthcare reform and healthcare delivery so that all patients are treated within this model of thinking in terms of improving outcomes and driving towards value. And then the third prong of this is around long-term services and supports, and that's a function of home and community-based services and nursing facilities. Our TennCare Medicaid program is a significant payer in this space. We pay for a significant portion of the nursing facilities care delivered in the state, and we are moving towards value-based purchasing for this model as well. And there's several different initiatives at work there, and I won't talk a whole lot more about that because it doesn't directly relate to primary care transformation, but just to let you know that there are the same type of services and same type of programs going on around long-term services and supports. This next slide takes a look at the stakeholder process, and I've already mentioned that we've tried to bring as many payers to the table as possible. Our managed care organizations, commercial payers, Medicare Advantage plans, really payers across the whole spectrum, but also have tried to bring as many other stakeholders to the table as well, and have had over 1,000 meetings now since 2013 with over 250 different stakeholder groups, and these have included provider groups. Tennessee Hospital Association has been very active in this process. Tennessee Medical Association, really professional organizations across the whole spectrum representing different primary care and specialty groups. Specific providers as we brought in clinical expertise for different issues, and I'll talk more about our technical advisory group process here in just a moment, but also the employers. And the employers have a very keen interest in what's going on in terms of development of these processes, and they are very actively moving towards the kind of value-based payments because they are the ones who have a good portion of the funds at stake in terms of paying for health care. And finally, the public. We've had meetings where we brought in representatives from the public to get their input as well. And I can say that, I mentioned earlier that there are these initiatives going on across the whole country in terms of different payers and different organizations trying to reform the system. But in many ways, Tennessee is right on the front edge of developing this program and healthcare reform. TennCare has a long history of being on the front edge of developing and implementing Medicaid initiatives that are cutting edge. Going back to 1994 when the program was started, it was the first Medicaid program to go to managed care, and now over 80% of all Medicaid enrollees across the country receive their services through managed care organizations. So we were on the front edge of that, and have been on the front edge of many other initiatives over the last 20 years, and very much on the forward edge of developing these payment reform initiatives. And I think as we've had the opportunity to talk to providers and other representatives in the state and really across the country about the progress that we're making, we are leading the charge in many regards. And I think as we are able to get things figured out in Tennessee, we have the opportunity to influence positively the national debate on healthcare reform. And I think the one thing that basically everyone I've talked to agrees on is that 10 years from now, the delivery of healthcare will look very different than it does now, that the payment system will be much different, and we have a real opportunity as we move forward in Tennessee to influence that in a positive direction. So the next slide looks at some of the problems with our system that we have right now. It tends to be very siloed. There's not a lot of incentive or opportunity for providers across the whole spectrum to communicate or integrate care in a way that's optimal for the patient or cost-effective to the system. And so we are looking at ways to change this in a couple different directions. And one is around changing the incentives for providers and providing payment models based on the outcomes that you receive, and we'll talk a good bit more about that. And the other prong of that is around improving information flow and giving access to physicians and other providers who are seeing patients, and as you have that patient in front of you, to have better information to be able to make better decisions clinically. And there's a lot of opportunity around technology for improving the flow of information and doing that in a way that is not administratively burdensome to you as you're working with your patients, but to actually give you better, helpful, meaningful information to improve the types of interactions you're having with patients. So let me stop right there. That's the introduction, and from here I'm going to go into a little bit more depth about primary care transformation, but are there any questions up to this point? Great. Let's talk about primary care transformation, and in terms of that transformation, there's two primary prongs to that. One is around the patient-centered medical home, and the second is a subset of that which we've called a health home or a health link, which is designed more for patients with severe and persistent mental illness. So for behavioral health conditions, we have a separate behavioral health home, which is designed primarily for behavioral health providers, for community mental health centers and other psychiatric or psychological practices to be able to direct their resources in a more efficient way to those patients who have severe psychiatric conditions. The idea behind the patient-centered medical home is that every one of our patients within the TennCare system will be assigned to a primary care doctor, and that's already been completed. Every one of our enrollees now has a primary care doctor that they're assigned to, and to have a relationship with that primary care doctor such that they know who their doctor is, that their initial instinct or reflex when they have any kind of medical problem is to go to the primary care doctor and talk to them first, and whether that's an acute or a chronic problem, that's their first entry into the healthcare system. So they know who their primary care doctor is, and just as importantly, you as the primary care doctors know who your patients are. So you have a panel of patients, and you're able to get information about them and know what's going on with them, both in terms of your own practice, in terms of information from the payers, but also information from other providers who are seeing your patients, whether they be specialists or facilities or hospitals or or any place along the whole spectrum of care that they could be receiving treatment, that you have access to be able to get that information. And the benefit to the whole system, I think, is pretty clear, that there is improved flow of information, improved quality of care. There's opportunities for integration and collaboration, and the avoidance of repetitive testing and waste and overutilization that occurs frequently now in the system. And as information flows better and communication occurs more readily, that the decision-making process is improved, and we end up with improved results: decreased readmissions, decreased ER visits, decreased complications, and overall improved health, and move from a system of sickness care to one where we're actually focusing on wellness and improving people's quality of life to allow them to optimize their overall life. So this talks a little bit about what does the HealthLink model look like, and so we'll talk about HealthLink in terms of the members in the program. The first wave of HealthLink homes started on December 1st. So we're just now in the very early stages of initiating a HealthLink in the PCMH program, and that started on December 1st. Those are primarily community mental health centers. 21 of those practices began just a few weeks ago, and a couple components to that. One is additional payments, so a PMPM payment for initiation of changes to the practice, for additional services that would be provided, and also the opportunity for outcome payments based on results, and particularly cost effectiveness. So an annual opportunity for a bonus payment based on the overall cost of the patients that they're treating under their health home. But in addition to changes in the payment structure, other resources that are not currently available to providers. We have a contract now with a training vendor, which will begin their services in January. They will be going out to practices, to behavioral health practices, and to primary care practices, and providing training on how to move towards the patient-centered medical home model, how to improve best practices and flow of information and patients within your practice, how to best utilize resources to improve overall quality of care. You'll be receiving, as a primary care or a health home, quarterly reports that you don't have currently access to. So on a quarterly basis, for everyone within your patient population, in your pool of patients, you'll receive a quarterly report for how they're doing, both in terms of quality metrics and cost effectiveness. And also a care coordination tool, which is a portal where you can log on and get additional information about your patient population. So you find out who your patients are and find out what's happening in terms of their care. And the initial flow of that information will be in the form of information on pharmacy data, on data from the MCOs, such as claims data, and data from the hospitals, admission, discharge, and transfer data that will be transferred into that portal in order to give you information about whether your patients had been admitted to the hospital, discharged, or transferred. And that's a flow of information that most providers don't have access to right now. And I think over time what we're moving towards is a system where there is more of a seamless flow of information between different types of providers, between hospitals and primary care doctors, between primary care doctors and specialists, and between facilities where diagnostic testing is done, so that we can get better information and avoid some of the overutilization and repetitive testing that's done that may be unnecessary. So that HealthLink overview is very similar to the model for patient-centered medical home as well. So as a patient-centered medical home, we'll be providing additional payments to the PCMHs based on the panel of patients that you have on a PMPM model, and that in addition to the opportunity on the back end for additional payments. The PCMH model will be beginning on January 1st, so in about 3 weeks from now, January 1st of 2017, the first 30 practices that are in the first wave of PCMHs will begin that process, and so they'll be receiving the same type of training that I just mentioned, that will be going out to the health homes, the additional resources, the access to the care coordination tool, and the quarterly reports. So you have the quarterly reports are more of a retrospective review of what's going on within your practice and within your patient population, And the care coordination tool is more real-time data that allows you to make better decisions with the patient in front of you. So the next slide just looks at the primary care care coordination tool. And you can see there's a flow of a lot of different types of information coming into that tool. ADT feeds, claims data, pharmacy data, and then the opportunity ultimately, and this is not there yet, but we're moving in the direction of the opportunity for different types of providers to share information through this care coordination tool. And that goes along with the quarterly reports that will be going to all the PCMH and health home providers as well. This is just a look at the timeline of how this is going to roll out. We have already finished the pilot of the care coordination tool here in 2016 and have that functional. And have also completed the contract for the vendor that will be providing services. The winner of that contract was an organization called Navigant, and Navigant will be going out to providers across the state beginning in January and providing the training I mentioned earlier. The Health Link model has also already launched effective December 1st, so we're very early in that model, but those additional resources are flowing to those providers, and we're looking towards accountability on how that their services are being provided. Effective January 1, the PCMH model for the first 30 practices will begin, and we'll have ongoing training and technical assistance. And in mid-2017, we'll be looking at the second wave of practices to identify them, and those will begin on January 1 of 2018. So this is a process moving towards a goal of having as many primary care patient-centered medical homes in the state as possible, to get as many of those appropriately accredited and get them optimally treating patients, and to move toward a model where ultimately all of our patients are receiving care through a patient-centered medical home. Something I meant to mention when I was talking about the stakeholders and shareholders in this process is that as we've created these patient-centered medical home and health link models, we've relied on providers to give us clinical feedback on how to do this in a way that doesn't create any unintended consequences or any type of perverse incentive that would be negative to the overall system. And in 2015, the second half of 2015, had a series of about 8 3-hour meetings where we brought in primary care doctors from across the state, all different types of practices, rural and urban, academic and private practices, multi-specialty groups, and all 3 regions across the state, and talked to them about ways that we could create a model of primary care that would work best in the state of Tennessee. And I think one of the challenges that primary care doctors have had over the last several years is that there have been several different models from different payers across the state of what is a primary care transformation. How does that work, and what does that look like? And what we tried to do is to have some standardization. We had a group called the NCQA, which is an accreditation organization at the table as part of that, and part of our model includes ultimate accreditation by NCQA and moving in that direction, and they have some very clear steps about what is needed to move towards the PCMH model, but also additionally some other opportunities that are unique to Tennessee that as we've created this model, we want to create a model that works first in Tennessee and primarily in Tennessee, and some of the unique challenges that we have in our state, including the fact that many of our providers, as you well know, are rural, and some of the unique challenges associated with practicing in rural communities where there's whole different opportunities and different challenges with facing those types of practices. So that's the model for rolling out over the next several years with primary care transformation. So that's it on primary care transformation. Are there any questions about that?
This is Bill Jolly at THA. So you sort of referenced the rural providers and sort of getting their perspective as you develop the various initiatives. As far as the initial launch, is there a good mixture of both urban and rural practices that will be impacted?
Yes.
And the Health Link initiatives?
There are, and so we've been trying to be very conscious throughout this process to include providers across the whole spectrum of care. So as we've chosen the first 30 practices, tried to choose practices from both rural and urban, from academic and private practice, and from all 3 regions in the state. So all those are represented, and we have both adult and pediatric practices, as well as family medicine, internal medicine, primary care provider, pediatricians represented in that in this initial wave, and trying to get as much feedback. The majority of the practices in this first wave are bigger practices. So as we move forward, we want to have practices and have access to practices of all different sizes, and realize that rural practices tend to be smaller, but there are rural practices identified and represented in this first group of both the patient-centered medical homes, but also in the health clinic and the behavioral health model as well.
Okay, thank you.
Yep, any other questions? All right, so episodes of care is, as I mentioned, designed to coordinate with the patient-centered medical home model. And so every patient has a primary care doctor that they have a relationship with that is their initial entry point into the healthcare system, but also a realization that the need for care, effectiveness, and efficiency and value goes beyond just the relationship with the primary care doctor, that there are other interactions that patients have in the system that we want to try to optimize. And that's where the episode of care portion of this comes in. And we had a similar process with the episodes of care, where we brought in, and we continue to bring in, these technical advisory groups for each episode, and bring them in. And where we start with every one of these groups that we bring in, technical advisory groups, is what we call the patient journey. What does it look like for a patient who's going through a specific episode? And the model that you see on the screen here is for a total joint replacement, which is one of the first episodes that we created. So from the time of diagnosis of arthritis through preoperative treatments and conservative treatments, through the surgery itself, and then the postoperative admission and discharge and rehabilitation. What does it look like for a patient going through that journey, and where are the opportunities for best practices or sources of value where we can improve those practices and try to drive care in a way that optimizes both outcomes and cost effectiveness. And those are the kind of discussions we have with these technical advisory groups. And in fact, we had the very same discussions with the primary care doctors when we brought them in last year. And for the primary care practice, that interaction of a patient journey really starts with birth and goes all the way to death, and is your relationship with your primary care doctor. But for these episodes, they're more constrained and time limited, so your interaction with your orthopedic doctor would be limited to your interactions around the total joint replacement. And as we develop those sources of value through these discussions, we then used those types of discussions to inform our recommendations for the parameters of what each episode would look like. And I'll describe that in a little bit more detail as we go deeper here. Let's see. All right. So the episode of care process, the episode of care model that we're using is a retrospective model. And what that means is that the initial process of patients seeking care and the providers delivering that care remains unchanged. And you would continue to see your patients for that episode. You would send in your claims, and that part of the model is the same. Payers reimburse you for your claims, and for each one of these episodes, the portion that changes is that there's a single quarterback or primary accountable provider who is assigned, who is most responsible for the overall care of that patient for that individual episode. And so that quarterback would begin receiving reports on a quarterly basis for all the patients that they see within that individual episode. So the first 3 episodes that we created were the total joint replacement, perinatal, and asthma. And so I'll use the example of a total joint replacement because that's probably the most straightforward one that we've created thus far. So for the total joint replacement, the initiation of the episode is the surgery itself, and the quarterback is the orthopedic surgeon who does the surgery. He's the primary accountable provider, and on a quarterly basis, he receives a report on the outcomes, the quality, and the cost of effectiveness of each one of those patients that he did a total joint replacement on the preceding quarter. And that's information he's never had access to before. I think some of the best practices are able to follow their own quality metrics and see how they're doing in terms of outcomes, but they're never been able to compare themselves to all the other practices in the state in terms of quality. And they certainly have not had the depth of information around cost effectiveness and the cost of the treatment that they're provided that are given in these quarterly reports. And so the quarterback receives this information, And each accountability period is a year long. And so this slide I'm going to show you now is probably the most important in terms of understanding what the episodic care model looks like from the financial standpoint and from the financial incentive model. So the upper left graph of this curve is each individual episode for a given period, for the annual period. So if we think of this in terms of the total joint replacement model, this would be each joint replacement done by an individual orthopedic surgeon over a period of 1 year, and that's on the x-axis. And the y-axis is the cost of each one of those patients for the episode. And you can see that there's some variation in the cost for this particular quarterback across that year-long of treatment, but we then take an average of all the costs from the patients that he saw, and that's the graph on the upper right, the chart on the upper right, the single blue line. That's the average risk-adjusted episode cost for a given provider. And this is done at the tax ID level, so if you're in a multi-specialty group of 5 or 10 or more orthopedic surgeons, that you would be all under the same tax ID. And the other key element there is this is risk adjusted. So it's risk adjusted based on the comorbidities of each of those individual patients. So it may be that for a 50-year-old who is very healthy and has no other comorbidities, that the expected cost would be unaltered by their risks, and therefore there would be no adjustment necessary. But for an older patient, maybe has congestive heart failure and obesity and skin problems, that there would be a expectation of greater financial risk for that patient. And so risk adjustment would be performed based on those comorbidities to make sure that we're making fair comparisons and that we're not creating a system where sicker patients are not treated as fairly. And in fact, with a model that's risk adjusted, the greatest variation is in the sicker patients, and that's where the opportunity is. So if you have a patient who has a more complicated condition or more comorbidities, you would expect for that patient to be have more challenging outcomes and to be more costly. And if you can treat that patient in a way where their outcomes are improved and they're more cost effective, you would be able to share some of those savings. And that's what the bottom graph is showing. So if you take the risk adjusted spend for that first quarterback, the upper right blue line, and you move that down to the spend on the curve on the bottom, what we see on the bottom now is the x-axis is all the quarterbacks in the state, all the orthopedic surgeons who did total joint replacements over the course of the year, and the spend, the risk-adjusted spend for each one of those quarterbacks. And you can see those quarterbacks on the left side of that graph that are in the red are actually the higher cost providers after risk adjustment, and those on the right in the green are the lower cost. So there's two important lines on this graph that are key for understanding the cost and how the gain sharing and risk sharing is spread out. The first line, the upper line, is the acceptable line. So if your cost, your average costs are above that acceptable line, and those are those red providers, those providers would be required to pay money back at the end of the accountability period. So they're at risk for additional payments back. Those providers in the yellow are between the acceptable and commendable lines, and they would have no change to their payment. And then you see a line parallel to the x-axis, which is a commendable line, and those providers that are below that commendable line would be eligible for gain sharing, and they would receive money back at the end of the accountability period because they're low-cost, high-quality providers. The other element that's essential for gain sharing is you have to meet quality metrics to be able to gain share. So if you're a low-cost provider but you don't have high-quality outcomes, then you would not be able to participate in gain sharing. So that's the most important slide in terms of understanding the financial model of the episodes of care. And ultimately, we're going to move to a model that looks somewhat similar for patient-centered medical homes and primary care providers based on the overall spend for individual patients. Are there any questions about that? Great. So the other element beyond cost is quality or outcomes, and how do we measure that? And so measuring quality can be very challenging, and there's a couple different ways that we can go about measuring outcomes. One is around claims data, and so there's advantages and disadvantages to measuring quality based on the claims data that we receive. The challenge is that it's difficult to get really meaningful information from just claims data. So I'll go back to the example of the total joint replacement. If you have a total joint replacement and you were looking at the claims data, you can tell if that patient had an infection or a fracture or a complication or went to the emergency room or a readmission, but you can't really measure from the claims data impact, the positive impact that the surgery had on that patient's life. You can't tell if they were able to go back to walking around the block, or go back to work, or be able to enjoy spending time with their children or their grandchildren. And so from the claims data, we get the complications and process metrics, but we also look, as we talk about quality metrics, at other ways that we can gather information that would get to a more meaningful measurement of the impact of the quarterback or the primary kennel provider on his patient population. And so we have tried, whenever possible, to leverage existing sources. And so if there are registries that are already available that are already doing what we're doing, we don't want to reinvent the wheel, so we've leveraged registries. One example of that is for the colonoscopy episode that we've created. There's an existing registry that's called GI Quick, and we've worked very closely with them. We've worked with the Department of Health to gather information that they are already accumulating around the breast cancer episode that we've created, and around the HIV episode, and several other opportunities around vaccines where we've worked with the Department of Health, and any other sources, whether that be through surveys of patients or providers or other sources, to try to gather meaningful data. And so the distinction between claims data and non-claims data is one. The other distinction for quality metrics is that some of them are linked to gain sharing. So for some of these episodes, you have to hit certain metrics and certain percentages to be able to participate in gain sharing. And other metrics that are provided are just for information purposes only. And for those quality metrics where we can draw a clean line in the sand and say, if you haven't met this particular percentage on this metric, that you are not providing the quality that should be eligible for increased payments, then we have those linked to gain sharing. But others, it's difficult to draw those kind of lines, and so we provide those for information purposes to help you to make better decisions and to understand where your practice stands, but not to be tied to gain sharing. So the next slide is just giving an example of what these reports look like and the type of data that is available in them. And so on a quarterly basis, each one of the quarterbacks receives a report that gives them information about these quality metrics on a patient-by-patient basis. And this same type of report will be going to primary care doctors as part of the PCMH model for each patient within their patient population. And you'll receive information about the costs that were associated with that patient, and also about the quality metrics and the outcomes of the services that were provided to them. And that's on a patient-by-patient basis. And one of the feedbacks we got early was the ability to utilize that information optimally. And so now we provide the patient information in an Excel spreadsheet. And so when you get that data, you are able to take it and look at it in a lot of different ways, sort it through the spreadsheet, but also take that data and incorporate it into your electronic medical record or your billing system in a way that allows you to gain the most possible information and put that information to use to improve the practices within your organization. I mentioned earlier we just completed the 6th wave of episodes. We started in September of 2013, as this chart shows, and are now just completing 2016. So 6 waves of these, and about 30 of these episodes are created. The first 3 episodes I mentioned, perinatal asthma and total joint replacements, have just completed their first financial accountability period. And the initial data, and this is just from TennCare providers, was very positive. The amount saved from the episodes was $11.1 million, and the quality metrics were generally improved as well. So quality at least stayed stable, and in some of the metrics improved, and the overall cost of the services provided within those 3 episodes was very much improved over the first year. And that's a fairly limited population of just TennCare, and as it expands more, I think we'll see a greater improvement in the overall cost effectiveness of our care, and that's in the context of healthcare spend that's been increasing rapidly for years, and over the last year has increased significantly as well. So we were able to lower costs in that environment. So you can see there's a total of 11 of these waves that will be created over the next 3 years or so, for a total of 75 episodes by the midpoint of 2019, and as they are completed and rolled out, they'll just continue to roll on along with the patient-centered medical home to the point where essentially all the spend in the state will be going through some form of value-based payment within the next 5 years. And as I mentioned earlier, this is also consistent with what CMS and other commercial payers are doing in other parts of the country. So the Medicare model is moving in this direction. They have some episodes of care that look somewhat similar to this. So I think there does seem to be some coalition around these two models of episodes of care for acute interactions and primary care transformation or patient-centered medical home for the bulk of the chronic conditions that are treated. I'm not going to spend too much time on long-term services and supports. I'll be glad to answer any questions you might have about that, but this is primarily talking about the payments related to nursing facilities and home and community-based services in the state. And as I mentioned earlier, we're moving towards some value-based payments and measuring those organizations based on the outcomes that they achieve as well. So I'll skip the slides around the long-term services and supports and just go to this slide. And if at any time you have any questions around payment reform in the state, there's an email there you can reach. There's a tremendous amount of information on our website. Everything I talked about today is available with a whole lot more detail around the episodes of care, the patient-centered medical home model, what that's going to look like, how we came to the process of developing it, and in the direction that's going over the next couple years. There's tremendous opportunity for involvement in the system as well. If any of you have an interest in participating in any of our provider meetings or any of our technical advisory groups, you can get on our email list and you'll receive regular updates about where those opportunities exist. We're regularly asking for participation in these groups, and we'll be starting another wave of these technical advisory groups for Wave 7 in January. So asking for providers from different specialties at that point, depending on which episodes are being created, to come in and talk about where the opportunities are within your individual specialty. So if you would like, you can get on that email list and get regular updates on everything that's going on around payment reform in the state. And otherwise, let me stop there and see if there are any questions. If you have any questions now, I'm glad to stay on the line and talk for as long as you like. But otherwise, you can also email me at any time if there's ever any questions or issues you'd like to discuss. So, any questions?
This is Bill Jolly at THA again, just to make a comment. As we stated on the front end of the call, we did actually tape the webinar. We'll be communicating the availability of the webinar to a network of our primary care providers and other employers of primary care physicians. If we receive any additional questions or comments, we'll communicate those to you if that's acceptable.
That sounds great. I very much appreciate the relationship we have with the Tennessee Hospital Association. It's been very positive, and appreciate the opportunity to be on the call tonight. And I'm always available if you have any questions about what we're doing around payment reform or really anything to do with the TennCare program. We are very open to feedback, and one of the things we've tried to be conscious of is that it's easy to make decisions here in Nashville related to healthcare delivery without understanding the impact that it could have out in the community, particularly in rural providers in rural communities. So we are very thankful for the feedback that we receive and try to act on it appropriately.
Well, thank you again. This is very informative. And again, if we get any follow-up questions or comments, we'll certainly communicate those to you. But thanks again for your time.
Great. Thank you very much. Have a wonderful evening.
Thank you.